We know that chromosomal abnormalities usually are occurring by chance. They can occur as an error in the egg or the sperm, but we know that there's an association between the age of the person providing the egg and the chance for chromosomal abnormalities. Females or those who are assigned female at birth, we're born with all of our eggs. And as we are getting older, so too are the eggs. We do see that there's a higher chance for chromosomal abnormalities as the person providing the egg is getting older.
Can you give us some guidelines as to what is the expectation on the rate of chromosomal abnormalities of embryos based on age?
Hi, superhumans. I'm Dr. Mavis Garcia.
And I'm Dr. Wise.
We're two of the physician leaders at Markham Fertility Centre, otherwise known as our baby, MFC.
As fertility specialists, we've witnessed firsthand the challenges, triumphs, and the myriad of emotions that come with trying to conceive. Whether you're just starting to think about having a baby, actively trying, or facing challenges along the way, My Fertility Podcast will be your go-to resource for honest conversations and a supportive community.
So grab a cup of coffee or tea and settle in, and let's demystify the world of fertility together.
On today's episode of My Fertility Podcast, we welcome back Diane Myles Reid, who is not only the president of the Canadian Association of Genetic Counsellors, but she is also the lead genetic counselor here at Markham Fertility Centre. She is a wealth of information and has a wide breadth of knowledge, and we're going to hear all about PGT-A today.
Welcome, Diane. We're delighted to have you today. I know this is a topic that so many of our patients are asking us about. They are seeing lots of information on social media about it. So I think this episode is long overdue, and we are very excited that you're here to shed some light on this topic of pre-implantation genetic testing.
Thank you so much for having me. I'm so excited to talk about something that's really close to my heart and to share everything I know about pre-implantation genetic testing for aneuploidy.
Which is a lot. You know a lot about pre-implantation genetic testing and aneuploidy.
I'm really excited to have this conversation because it's not black and white, really. It feels like it's all shades of gray. And it's a very nuanced conversation depending on the patient's situation, the previous history. I'm so excited to be able to dig into that nitty gritty and to try and shed some light on this topic to help guide people in terms of making those decisions that are right for them.
All right, let's get right into it. Diane, tell us, what is PGT-A?
Let's break it down. PGT-A stands for pre-implantation genetic testing for aneuploidy. That's a little bit of a mouthful. We generally refer to this as PGT-A for short. PGT-A is a test that we can do on embryos that have been created with IVF in order to have information about the chromosomes, which are found within the cells of the embryo. And specifically, PGT-A can tell us, is there the correct set of chromosomes within the cells of that embryo, or are there any chromosomal differences or abnormalities that are found within the cells of the embryo? And this is important information because we know that if there are chromosomal abnormalities within the cells of the embryo, then that embryo will have a low chance of success. Whereas if we find embryos that are chromosomally normal, we know that those embryos have the highest chance of success, highest chance of implantation and ongoing pregnancy of the embryo.
Can we take a second and just plunge a little bit into genetics 101 for some of our listeners? What's the difference between, we use the term DNA, we say genes, we say chromosomes. Is it the same thing? Is it different?
Absolutely. That's a great question. We as humans are made up of millions and millions of cells. And if we're thinking about our embryos as well, embryos are also made up of cells. And within the cells of a human, as well as the cells of the embryo, we have this set of chromosomes. And the chromosomes are made up of our DNA and genes. So you've probably heard about DNA. DNA is that molecule that makes up our genes. Our genes are really providing instructions that tells the embryo how to grow and develop within our bodies. The genes are telling our bodies how to function from day to day. So our genes really provide those very important instructions. And all of our genes are packaged into our chromosomes. So each chromosome has hundreds and thousands of genes. And in every cell, there should be a set of chromosomes, and the usual number of chromosomes is 46. Chromosomes come in pairs because our genes also come in pairs. At the time that an embryo is created, there's one set or half of the chromosomes that should be present in the egg, whereas a second copy of the chromosome is present in the sperm. There should be 23 chromosomes in the egg, 23 chromosomes in the sperm coming together so that there should be 46 chromosomes all together in every cell of the embryo. PGT-A testing is really DNA testing that can look at the chromosomal DNA to determine, are we seeing the correct set of chromosomes within the cells of that embryo, or are we seeing that there's an extra or missing chromosome, or even parts of chromosomes that might be missing or extra within that embryo.
Thank you so much for that explanation. Now, with all of that in mind, what is the ultimate goal of PGT-A?
Great questions. The purpose of PGT-A is to have information about the chromosomes within the cells of that embryo. This information is important because we know that chromosomally normal embryos have the highest chance of implantation and leading to a successful pregnancy. So having PGT-A results for your embryos can allow your doctors and the lab to choose the best embryo to put back into the uterus for a pregnancy.
And now we're going to get into more details of that because, as you know, this is simplistic. There's a lot of nuances to that statement, right? So we're going to get into all of it. Tell us, how are embryos tested for PGT-A?
When the egg and sperm come together to create an embryo, the embryo is going to be growing in the lab for 5 or 6 days until it becomes a blastocyst embryo. And the embryologist will select those good quality blastocyst embryos to biopsy and sample for PGT-A testing. When an embryo is a blastocyst, it's made up of 1 to 200 cells. There's this outer part of the embryo referred to as the trophectoderm. These are the cells that will develop to become the placenta and tissue supporting a pregnancy. There's also the inner cell mass. Those are the cells that will develop to become fetus and the baby. And the embryologist will remove 5 or 6 cells from each embryo from the trophectoderm part of the embryo.
Why can the embryologist not remove cells from the inner cell mass?
Mhm. That's a great question. We're not able to remove cells from that inner cell mass because we don't want to cause harm to the developing baby. And so we believe it's safe to take 5 or 6 cells from that outer part of the embryo, and then the embryos are frozen here at Markham Fertility Centre. The biopsied cells would be sent to an outside PGT-A lab for DNA analysis.
I'm glad that you mentioned that. The embryos are never leaving Markham Fertility Center. It's only the biopsy sample that is leaving to be tested. I know a few patients have said, oh, my embryos are going away. And no, they're not going away. They're always staying here.
That's so
Mhm.
important because you're right. Everyone thinks we're sending their embryos out to an outside lab. And absolutely, embryos are remaining safe and sound here at Markham Fertility.
I want to refer you back to episode 14 on IVF, where we talk about the normal drop off in an IVF cycle from eggs that are fertilized to embryos that become blastocysts. And that's really important because when we talk about PGT-A, we're talking about embryos that have fully grown into the blastocyst stage, not all the embryos that you've made in a cycle. And it's crucial to understand that even if you have 10 or 12 embryos to begin with on day one, the number of embryos available to biopsy would be much less than that. Usually, about 40 to 50% of embryos that fertilize on day one would become embryos available for biopsy. And on that note, not every embryo that becomes a blastocyst is actually available for biopsy because that embryo needs to hatch out of the cell. It needs to have a certain morphology so that the embryology feels confident that doing the biopsy is not going to affect the viability of the embryo.
PGT-A is testing for chromosomal abnormalities in embryos in the context of IVF. But Diane, how do these abnormalities happen? Where do they come from?
We know that chromosomal abnormalities usually are occurring by chance. They can occur as an error in the egg or the sperm, but we know that there's an association between the age of the person providing the egg and the chance for chromosomal abnormalities. Females or those who are assigned female at birth, we know that we're born with all of our eggs. And as we are getting older, so too are the eggs. We do see that there's a higher chance for chromosomal abnormalities as the person providing the egg is getting older.
Can you give us some guidelines as to what is the expectation on the rate of chromosomal abnormalities of embryos based on age?
It's interesting because some people think that if they've used an egg donor, someone who might be younger at the time of egg retrieval, or even if they themselves are in their 30s, they think that perhaps there's not a high chance or there's not a chance for their embryos to be chromosomally abnormal, but it is a chance occurrence. And I guess even for people who are younger, perhaps in their early 30s at the time of egg retrieval, we still do see that some of their embryos can be chromosomally abnormal. It's probably in the order of maybe about 30% of embryos. And we know that as the age is getting higher, the age of the egg, then we do see a higher chance for chromosomal abnormalities. At the age of 35, it's probably around 50% chance that an embryo would be chromosomally normal. And as the age of the egg is getting older, there's an even higher chance that there could be chromosomal abnormalities in embryos.
What is it at age 38, for example?
At the age of 38, we would say that approximately 30 to 35% of embryos are chromosomally normal. And someone who's at the age of 40, probably 10 to 15% of embryos are chromosomally normal.
Wow, that's a big decline, especially as a woman's getting to her mid to late 30s.
Yeah. And again, we're talking about testing maybe one embryo at age 40, right? And now that one embryo has a 10% chance of being chromosomally normal.
Mhm.
Absolutely. I think that, yes, I think this speaks to the importance of PGT-A or perhaps the usefulness of PGT-A. Some would say that perhaps it's more beneficial as a woman is getting older, as the eggs are getting older, and it can be more useful to really find those embryos that are chromosomally normal. As you know, we tend to see fewer embryos created in an IVF cycle when the age of the egg is older. And so perhaps even more critical to use this technology to find the embryos that are normal and to avoid transferring those embryos that are chromosomally abnormal.
You've talked about the benefits of PGTA, which, as you know, there are many, but what are some of the risks associated with doing PGTA on embryos?
One of the important considerations is the awareness that the embryos may all be chromosomally abnormal. Some people will ask me, what happens if all of my embryos are found to have aneuploid or abnormal results with PGT-A? And in that case, unfortunately, those embryos would not be recommended for transfer. So I think that's a really important consideration. The risks, I mean, some people are worried about the risk of biopsy. The biopsy itself is generally felt to be safe. Yes, there's always a risk with every sort of technique that we use, and removing a few cells from that part of the embryo is felt to be safe. Although we know that there's always going to be a small chance, perhaps, that the biopsy could cause harm to the embryo and cause that embryo to stop developing.
Another really common question, at least I get asked. Okay, you do the PGT on the embryos. Presumably, you're looking at the sex chromosomes. So, can I find out the sex of my embryo with PGT-A?
In Canada, there are laws that suggest that we cannot provide that information. If embryos are chromosomally normal or abnormal, we're not sharing the sex chromosome information. The only exception to that is if there is a genetic condition that's limited to the sex chromosome. Some conditions are more common in females, some conditions are more common in males. And in that case, if there was a genetic condition that was more common in one sex over the other, then that's an exception and those results could be released.
So it is only for specific medical conditions that we can release the sex of embryos. Mhm.
Mhm.
So a lot of questions. Okay, so I'm going to do PGTA, and if my embryo comes back normal, doctor, does that mean my baby's going to be healthy? Does this guarantee me a healthy pregnancy?
PGT-A is a good test. It's a good technology, and the results are highly accurate. We generally say that PGT-A results are greater than 97% accurate. However, it's not a guarantee. And so we know that chromosomally normal or euploid embryos have the highest chance of implantation and ongoing pregnancy. However, there's no guarantee that transferring a chromosomally normal embryo will result in a pregnancy or a healthy baby. PGT-A testing is really looking at the chromosomal DNA with the purpose of selecting the best embryo for transfer.
Can PGTA look at autism, ADHD, psychiatric conditions, anything like that?
No, PGT-A is really looking at the chromosomal DNA and cannot test for single gene conditions. So those conditions that might be inherited from a parent. We also cannot test for things like intellectual disability, any of those complex traits. Some people are always asking, can we determine how tall our child will be, or can we test for autism? And no, the simple answer is that no, PGT-A testing is really looking at chromosome level, looking at the chromosome DNA within the embryos, and it's quite specific for that. So we're not able to look for single gene inherited genetic conditions or these complex traits.
You mentioned that PGT-A embryos that have been tested and they're normal have the highest implantation rate. Do you want to give us what that number? It's like I know what I tell my patients the number is like for a chromosomally normal embryo.
Sure, absolutely. So here at Markham Fertility, we generally will see that a euploid embryo has about a 65 to 70% chance of a pregnancy.
I wish it was 100%, but it isn't. And there's could be a lot of reasons for that. I always tell patients testing a PGT-A embryo that is chromosomally normal is like saying that somebody has a good heart, a strong heart, but then you don't know about the kidney, the livers, the lungs, and all the other organs that are required to be alive and walking around. We know the genetics, and that's really important, but there are a lot of other pieces to the embryo that current technology is not able to test for yet.
Absolutely.
So, Diane, we've been talking a lot about PGT-A, but let's actually talk about when an embryo gets biopsy, what are the possible outcomes of the possible results of a PGT-A test?
Mhm. That's a great question. Of course, one of the possible results is that the PGT-A tells us that there's a normal chromosome result. And we use the word euploid to refer to a normal chromosomal embryo. That's what we're hoping for. We hope that for people who are doing PGT-A testing, that we find one or more euploid or chromosomally normal embryo. We also know that some embryos can be aneuploid, which means that there are chromosomal abnormalities detected in the cells of that embryo. We can see that there is an entire extra or missing chromosome. We can see that there are multiple chromosome abnormalities. Sometimes we can detect that there are parts of chromosomes missing or extra. And in general, with PGT-A testing, when we find those chromosomally abnormal or aneuploid embryos, we will avoid transferring those embryos. We can also find embryos that are mosaic. And you're wondering, what is mosaic? Mosaic means that there are some cells within the embryo biopsy that are chromosomally normal and some cells that are abnormal. We know that mosaic embryos are associated with a lower chance of implantation and a higher chance of miscarriage. And on the other hand, we also now know that some mosaic embryos, if they are transferred, can result in an ongoing pregnancy and even a healthy baby. So we can maybe dive into mosaicism a little bit more.
Great.
Okay. And one other possible result that we have to talk about is that sometimes, even though the embryo is biopsied for PGT testing, perhaps the quality of the DNA or the sample is not adequate for a result. Even though the lab will sample the embryo and send it for testing, sometimes the PGT-A lab tells us that they're not able to provide an informative or conclusive result. And this usually happens, I would say, between about 3 to 4% of the time. So I think it's important to know that that's a limitation of testing embryos. Sometimes it's related to the number of cells that are biopsied or the quality of DNA within those cells. And one of the challenges or limitations of testing embryos is that we're very much limited to biopsying only a few cells from each embryo and then relying on those cells to provide an answer about your embryo.
Now let's dive into mosaicism. I remember when PGT first started, at least at Markham Fertility, when we started doing PGT-A, I think it might have been 2015 or 16 in that range, maybe earlier. We were all scared of mosaic embryos. And then that big study came up and we know better. And now we've had some babies born from mosaic embryos. So let's dive into that.
Yeah. So I think it's really important for people who are doing PGT-A testing to know that it's possible that one or more of their embryos may have a mosaic result. Yes. Now in 2024, we have more data that tells us that transferring a mosaic embryo can result in a pregnancy and healthy pregnancy, healthy baby. We still do know that oftentimes when we transfer mosaic embryos, there is no implantation or that there's a higher chance of miscarriage. I think our approach here at Markham Fertility Centre is to meet with people to really dive into their mosaic embryo results to discuss the chromosomes involved, which chromosome was found to be abnormal within the cells of that mosaic embryo, the level of mosaicism, whether there are a lot of cells or only a few cells that have that chromosomal change, and really what are still some of the limitations and considerations with mosaic embryo transfer. I think it's important that everyone has a chance to learn more about their mosaic embryo and decide if they are comfortable or want to transfer that embryo. Transferring a mosaic embryo can bring some uncertainty because we know that still there is a higher chance of no implantation or miscarriage. Some people are not comfortable to transfer their mosaic embryos. I think, on the other hand, if that's the only embryo that you have remaining for transfer, some people are wanting to transfer that embryo. And sort of a big part of my job here at Markham Fertility is providing that support and information to patients as they consider their mosaic embryos.
Every mosaic embryo is a little different. You cannot just make a general statement about every mosaic embryo. So that's why it's really important to talk to a genetic counselor before thinking about transferring your mosaic embryo. And I don't want to get out of topic here. We're going to do a whole new episode on prenatal testing and options that are available once you're pregnant. But I just want to say that whether you transfer a mosaic embryo or you euploid embryo, there is always options for genetic testing in pregnancy as well, which we're going to cover in another episode. So stay tuned for that.
I'm going to put you on the spot here, Diane. And this is a two-part question. One is, according to the textbooks, the evidence, guidelines, who should be doing PGT or who is PGT-A for? Part two is, in your experience, when you're counseling patients, when you're talking to patients, how do you explore whether that person should, air quotes, do PGT-A? And what are those nuances and the subtle differences between, let's say, the textbook answer versus the real world, real life answer?
Absolutely. Certainly within the fertility world, there are some clinics and physicians that use PGT-A in their clinics a lot. And there are some that maybe question the benefit or usefulness of PGT-A testing. Here at Markham Fertility, we do offer PGT-A routinely. A lot of our patients opt in for PGT-A, but there is a lot of discussion with each patient as they're considering PGT-A to help them decide if this is the best test for them. Some of the considerations, the number of embryos available, their history, what's brought them to the clinic. Have they had miscarriages before? Have they perhaps transferred embryos that were not tested? The age of the person providing the egg. What's the chance of chromosomal abnormalities in their embryos? These are all things that we would talk about and think about to help people make a decision about PGT-A testing.
Diane, we know that here at Markham Fertility Centre, we do a lot of PGT-A. And I have to admit, I am a big fan of PGT-A for all the reasons that we described. However, not everybody feels the same way. And there are some people that are quite critical of PGT-A. And everything that we want to do here in the podcast is give our listeners a balanced view of the fertility world, because these are big decisions to be made. Can you tell us a bit about what is the criticism of PGT-A and why somebody may be hearing mixed messages about the usefulness of PGT-A?
That's a great question, Dr. Garcia. I think, yes, there are certainly some fertility doctors that are critical of PGT-A testing, and some patients decide that PGT-A testing is not right for them. One of the concerns is that we are very much relying on just those 5 or 6 cells that we've biopsied from your embryo, and we cannot guarantee that result is 100% accurate. We cannot guarantee that there's a chromosomal abnormality that's present in all of the cells of the embryo. And so it's possible that we might, with PGT-A, tell you that the embryo is aneuploid and choose not to transfer that embryo, when there's always going to be a small chance that that embryo could have resulted in a pregnancy and live birth. So that's certainly one of the considerations and critiques.
Diane, let's say you have a patient who's coming to you, they've done PGT, they had all aneuploid embryos, for instance. And they say, you know what, I was on social media, or I saw another physician, or I talked to even another genetic counselor, and I'm hearing that aneuploid embryos can lead to healthy babies. How do you counsel patients around that scenario?
I think there's a very low chance that a uniformly aneuploid embryo could lead to a successful ongoing pregnancy. Probably greater than 98% of aneuploid embryos that are transferred would not result in a chromosomally normal live birth. We know PGT-A testing is highly accurate. It's not 100% accurate. There's always going to be a small chance that an embryo with a PGT-A aneuploid or abnormal result could be mosaic or even euploid. And so, again, there's never a 100% guarantee for a PGT-A result. But certainly, the majority of chromosomally abnormal embryos will not result in an ongoing pregnancy with a baby with normal chromosomes.
Mhm.
And I
Perfect.
think this is also really important in the real world, so to speak, because let's say you have somebody who is 39 or 40 years of age and she's made 3 embryos and she didn't do genetic testing, or there are aneuploid, but let's say you're ignoring the PGT-A results because of that small percentage that we talked about. Well, what that really means is that this person is now going to transfer this embryo. There is a financial cost to an embryo transfer. There is a huge emotional cost to the embryo transfer. There's medications to be taken. There is time off work. And then if there is no pregnancy, or worse, if there is a miscarriage, now we're looking at maybe 3 to 4 months that are wasted from the fertility journey on this embryo that had less than a 2% chance of resulting in a live birth. And then if you're talking about another embryo than another embryo like that, this can potentially be 6 months to a year. And that can make the difference between this patient being successful and not being successful at the end of their fertility journey. Because when you're older, 6 months to a year can have very detrimental effects on the ability to eventually obtain a chromosomally normal embryo. So certainly there is an argument to be made perhaps in the younger patient population, but certainly for patients that are older, timing is so essential that we really cannot afford to transfer embryos that are not genetically tested or chromosomally abnormal because of the high risk of miscarriage and the impact of time on long-term outcomes for fertility treatment.
And along those same lines, even in the younger patient population, I think Dr. Garcia and I, we both had patients who are, let's say, under 35. They make 5, 6, 7 blasts. Oh, it's a great cycle. Awesome. And then we're just doing transfer after transfer after transfer that's failing because, as you said, statistically, for a patient under 35, we think that half of the embryos are going to be genetically normal. But that's not always the case for everyone, right? Meaning that most people are going to hit that average number, but there's always people who are going to do better and there's people who are going to do worse in terms of the euploidy rates. PGT can help us narrow in and figure out which embryos to use faster. And I think that kind of goes to this idea of PGT being an embryo selection tool. This is a term that's come up only relatively recently, maybe in the past few years, that PGT really is an embryo selection tool. And so can you talk a little bit about that? What does that mean? What came with this kind of shift in thinking about PGT?
I think one of the greatest benefits or advantages of doing PGT-A testing is perhaps to find those embryos that are chromosomally abnormal and to avoid transferring them. We know that there's a high degree of accuracy with PGT-A testing. PGT-A can allow us to prioritize transfer of chromosomally normal embryos or even mosaic embryos and avoid those aneuploid embryos. That in turn may allow a patient to have a successful pregnancy sooner. So, one of the important considerations is time, emotions, money, all of those things. And if you have a chromosomally normal embryo identified with PGT-A testing, then we would prioritize that embryo for transfer. We now know that some mosaic embryos have equal success rates to euploid embryos. And so having that information about your embryos can also be useful in determining which embryos to transfer first. Financially, there could be advantages if you're doing PGT-A testing because while, yes, there is a cost to do the testing, you may have fewer embryos transferred before having that successful pregnancy. So, in the end, there could be a financial savings if you're doing PGT-A for your embryos. And then you touched on another super important consideration, which is the emotional impact. PGT-A can give us that information. It can allow us to avoid transferring those chromosomally abnormal embryos, which are most likely to not implant, although certainly there are some chromosomally abnormal embryos that might implant, lead to pregnancy, and then result in a miscarriage in the first part of the pregnancy. And then there are some chromosomally abnormal embryos that could even lead to an ongoing pregnancy and birth of a baby with a chromosomal condition. And so I think these are all important considerations for people who are considering PGT-A.
I tell my patients that it's a little bit like having money in the bank, but not knowing what currency it is. So if I tell you I put $10,000 in your account, but is it American dollars, Canadian dollars, is it Cuban pesos, which by the way, it's not worth very much. But so if you don't know this, you have no idea how to plan, right? Like, can you buy ice cream? Can you buy a house? You don't know. So that's the analogy that I like to use for patients to explain the concept of how important it is to know what is the potential of these embryos.
Yeah, please.
I was going to say another benefit is that we're freezing embryos. And so PGT-A gives you information about the embryos that are also stored here at the lab. It gives information perhaps for long-term planning. So some people feel that PGT-A testing really allows them to know the results for their embryos, know how likely they are to build their family with this IVF cycle and the embryos they've created in this cycle versus perhaps considering another IVF cycle. Some people know that maybe they want more than one child, or they know that there's not a guarantee if they only have one euploid embryo. And so PGT-A testing can perhaps allow you to have the most information about your embryos and plan for future.
I actually think that's the most important application of PGT-A personally, right? In the sense of that if you're having extra embryos that you're storing for future, there's so many hopes and dreams riding on those embryos. Let's say that you're planning for baby number 2 or whatever, that not knowing the genetics puts you at such a disadvantage in terms of having a true understanding in terms of what are the odds of success and whether you need to think about doing another cycle now to bank more embryos for the future, or whether you're in a position where the stats, your odds of success are at a point where you feel comfortable with those numbers, right? I love that analogy with the currency because that's exactly what it is. You've got embryos, but you don't know if they're good embryos. You don't know if they're bad embryos, so to speak, genetically abnormal embryos. So how much can you really rely on what's there, those frozen embryos, in terms of thinking about the future, which, that's the beauty of freezing embryos, that you have something for future to use, right?
I just wanted to add a note about the financial aspect. PGT-A is not covered by the Ontario Fertility Program. So if you're getting a funded cycle, PGT-A needs to be paid separate from that. Here at Markham Fertility Centre is July 2024 at the time of this recording. The payment of PGT-A is based on the number of embryos that you have. So it's per embryo. If you have one embryo, you're paying less for PGT-A than if you have 2, 3, or 4 embryos. It's not the same in every clinic. So it's important that if you're not a patient of Markham Fertility Centre, you ask specifically about what is the payment structure for PGT-A at the clinic that you're working with. But here it is per embryo, which means that if you don't have a lot of embryos, you're not paying more than you have to. And the other thing is that you can also determine the maximum number of embryos that you want to test. Let's say you have a budget of $5,000 that covers maybe about 4 embryos or 5 embryos, and you're making 8 embryos or 9 embryos. You can say, well, I'm going to test to a maximum of 5. The lab normally determines which should be the best embryos for testing, and the remaining embryos will be frozen without biopsy. They're still usable to you. They just don't have the information there. So that's another important aspect of the financial considerations when doing PGT-A. I really think this episode is going to help a lot of people understand the basis of PGT-A. Thank you so much, Diane. You definitely have a huge wealth of knowledge when it comes to PGT-A. I know that you are coming back. You cannot get away from us, cannot go too far. We're still going to talk about another part of PGT-A, which is PGT-M, and we're going to do another episode about the prenatal testing options. We can't wait to have you back.
Thank you so much for having me.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast, or visit us online at markhamfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful,
please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music from Mix Kit Raising Me Higher by Ajay Stelino. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.